And good afternoon to you.
Hi,
We're here talking to you today about labor.
labor. I love labor. That's my favorite part of being an OB nurse.
Is it?
I do. I love
I
labor.
miss labor. I'm not in the labor room as much as I ever was before. It is quite the time. There is nature that takes care of most of it, and I'm continuously amazed that nature gets it right. But sometimes it doesn't. And when it doesn't, there's trouble, right? So we're going to talk about when nature gets it right. We're going to talk about when things go awry with you this afternoon. Today's podcast is brought to you by Lifesavers Spearmint. Lifesavers here for
Yeah,
you.
that OG cervix shape.
Oh, the cervix. It does look a little like a cervix.
Mhm. The original. Nice closed circle.
Here it is.
No. That's honestly too, like I would say a fingertip dilated.
I'd say
Actually, that's
50 as well.
another one.
Mhm.
Look at it. It's like fingertip.
Talk to me a little bit about dilation.
Dilation. First stage of labor. Um, different things, right?
Hmm.
So we got dilation, because you gotta dilate in order to get a baby out
Hmm.
if you're going vaginally. So the goal is to get to 10 centimeters and open up quite a bit. And then other parts of a vaginal exam is the effacement. That's the thinning of the cervix. So your cervix pretty thick, right? So we wanted to thin out and then we want it to open, which is your dilation.
Okay.
Okay, I want to get that to 10 centimeters. Effacement, which is that thinning, we want to get to 100%. So you start at 0, goal is to get to 100. And then the other part of a vaginal exam is your fetal station. So babies start pretty high, -4, okay, -4,
Okay.
right?
All
-4.
right.
And the goal is to go into that positive direction. So like +4, baby's out, is what
Hmm.
we want.
So, I almost don't want to say it because I think I've said it about 18 times in the labor presentation in class, but I'm going to say it for the 19th time.
Okay. Well, I wasn't there for your class, so tell me.
The ischial spines, those are the landmark
Yep.
for when the head is level, the top of the head is level with the ischial spines at 0 station.
0 station, that's right.
Anything above it is -1, -2, -3. Anything below it is +1, +2, +3.
Yeah, that's that turning point. You're finally going in that positive direction.
Mm-hmm. All right. So we got to get through all of those things.
Yeah, before we get to expulsion, which is getting ready to push out a baby.
So the first stage, if you will, is all that hard work, quite frankly, in
Yeah,
labor. Yeah.
a little bit.
But it's not fair to talk about stages of labor without talking about phases of labor. There's a latent phase and
Mhm.
the
Active.
active phase.
Yeah.
And what's the difference between the two of those?
Latent phase is like your early phase of labor.
Okay.
So it's really just slow progression. Usually like 0 fingertip to like maybe 5 centimeters or up to 6 is going to be that latent phase. It takes longer to get up to 6 centimeters. And then once you're at 6, you're entering that active phase. So that's why we call it latent too. Early labor takes a while to get there.
Okay.
Also, that thinning of the cervix. Usually it's like maybe up to 40% or so. So it starts to thin out, but again, takes a while
Mhm.
for it to thin out because typically your cervix should not be thinning out when you're not pregnant. And then contractions is the other thing you have to look at because you need contractions. That's that power to get that baby out. And so usually there's no like good pattern to it. They might happen like every 5 to 10 minutes or so. So there's no good frequency.
So what you're saying is the cervix itself changes, obviously, depend and will start thinning out, opening up, and all that stuff. It's getting ripe, if you will. and labor helps it get bigger.
Yeah.
Open up the opening bigger. Um, talk to me a little bit about ripening or the Bishop score that we are looking at. If we bring a patient into like induced labor, they have a medical indication, or maybe they're overdue or getting close to overdue. We want to induce their labor. Talk to me about Bishop score.
Bishop score, we're going to do that type of, just like a universal score that we look at to determine if we need to do cervical ripening, which is like your fancy way of saying, do we need to thin out this cervix? Or just start dilating this cervix. And so it's out of 13. Ideally, if you're scoring under 5, though, usually you need some cervical ripening. So that's where we're going to give like Cervidil or Meso. And then anything above that, you're in a good spot to start Pitocin, which is what we use for augmentation or induction.
All right, so we need to ripen the cervix if the
Thin it
Bishop score
out.
is low.
Open it up, yeah.
As I think I said in class, I know I said it right here with us, you gotta unlock the door before you try to open it.
Yeah.
All right, there it is. Okie dokie. With the whole labor thing, the less glamorous part is the whole first stage of labor. I mean, it could take a long time,
Yeah.
and then you get to the pushing phase. And I was talking to my crew about how they could come to that second stage of labor, the pushing, like already pretty physically exhausted.
Yeah.
It's really important to use our time wisely. So when when the contraction comes, use it to push. And then when the contraction goes away, use the time to rest.
Yeah.
Everyone needs to gather their strength. We need to relax the uterus, allow for blood flow and oxygenation of our second patient in there, and just gather the strength. This is a time where we might need to tell everyone, okay, let's take 1 minute of just quiet. And then, all right, here it comes. Let's do this again. And like, so use that time to really rest in between.
Absolutely.
Pushing constantly is going to tire everyone out. And more importantly, stress the kid out.
Yeah.
Yeah. All right.
No, we don't want to do that.
No, we do
Right.
not. Sometimes, we obviously want the head to be down when we're pushing a baby out of the
Ideally.
pelvis, yes.
Yeah.
But it's head down is not the whole issue. Head down, I mean, like, there's more to it than just head down, basically.
Pretty much where that baby's head is.
Right, so I mean, like, and most of the time when we're talking about fetal position, we are kind of determining where the back of the baby or the occiput of the baby, where the occiput is in
Yeah.
relation to mom, basically.
Pretty
Mom's
much.
front or interior, mom's back, or
Yeah.
posterior, mom's left, mom's right.
Yeah. Can I use your brain?
You
All right.
so
So
pick my brain.
can I pick your brain really quick?
Yeah, you
So
can.
babies have on their head like fontanelle, okay, 2 of them. And you have your anterior and posterior. And so you're usually looking at that posterior because that's on the occipital bone.
Okay.
And so when we're looking at fetal position, we want to know where that occipital bone or that posterior fontanelle is to determine that baby's position. And is it facing mom's posterior side or her anterior side? Which part of the pelvis is it facing?
Okay.
So essentially what we look at. Thanks for letting me use your brain. Pick your brain.
You're welcome. Where's the front of this is the front or this is the back of the brain? What is that about?
No, that's the bottom.
I know that's the bottom. Is that the front or the back?
No, it's like this.
All right, so that's the back of the brain?
No, this is the back of the brain. Back of your head is ridiculous. Right there.
All right, well, that looks awful pokey. And I wouldn't want that thing pressing into my back. Guess
Yeah.
what? That's what happened in with my baby. My baby's the back of her head was pressing right into my back.
Yeah.
The occiput, her occiput, my posterior. So,
And those are hard babies to push out.
no, I didn't get a chance.
Oh,
I did not get a chance.
yeah.
Mhm.
OP babies are the hardest babies to push out. You gotta try to reposition mom.
To get that.
Hands
baby
and
out.
knees, yeah, to get that baby
Uh.
out. Oh, wait, that's the goal.
Occiput anterior. We want the back of the baby's head facing mom's front if possible.
Yeah.
Everything lines up better and there's less pain, so the rest of mom's musculature might be able to relax a
Yeah.
little bit more.
But you want an OA position. Even if it's left OA or right OA, it doesn't matter. Goal is that OA, right? You want that A on that exam. You want that baby to be in A position.
Oh, that's one way to look at it.
Yeah,
Head down. So there's more to the story. Just how is that head?
yeah,
Talk to me a little bit about when it's not head down.
yeah.
Our breech babies.
Breech
We
baby.
find a breech baby.
Hmm.
It all depends on when, where we are. Are we in labor? If
Well.
we're in labor,
Hmm.
taking a ride,
Taking a ride to that OR.
taking a ride to the OR.
Yeah.
These days, there's not very many practitioners, certainly not any malpractice insurance covered carriers will allow us to deliver breech babies vaginally anymore. Well, needless
The
to
only
say.
successful ones I've had is like really small preterm.
Yeah.
Otherwise though, if you're term,
You're getting a
big baby, you're
C-section.
getting a C-section.
Yeah. Sometimes if they are not in labor when it's discovered, like they do an ultrasound, blah, 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 about say 37 weeks. Baby still hasn't flipped over into a head down position. They may choose to do an external cephalic version.
Oh, what's that?
That's uncomfortable. That's what it is. It's mighty uncomfortable. And that is when literally the provider manipulates the baby from the outside of the abdomen, like literally tries to turn the baby to go head down.
Yeah.
Sometimes it works. Sometimes it works, and then boom, the baby flips back over again because I think the baby's just meant to be in that position. Who knows?
So you could do that at any point?
No. You could do it earlier, I suppose, but it's not going to be effective. Generally, we do it between like 36 and 38 weeks.
Gotcha.
We meaning the provider.
Okay.
We, the nurse, monitors very closely for any complications, uterine rupture of membranes, bleeding, fetal distress. Definitely discomfort with mom. Definitely.
Probably want an epidural for that.
If we can do an epidural, that's ideal. The other issue is we wouldn't be poking at somebody who's had a C-section before. That's a major contraindication. We're not gonna be manipulating that uterus that's already had a scar on it.
Makes sense, yeah. So want to do that a little bit earlier, right? Before that baby's too big too?
Definitely. We don't want the baby engaged. Well, first of all, it would be a butt or whatever engaged. But once that uterus kind of tightens up, it's also very difficult to move anything within
So
it.
before we have a big baby or that uterus starts having labor contraction.
Yeah, absolutely. One of the things, like we could be doing that and the water breaks and a cord comes down or some absolutely
Sound too
ridiculous.
fun.
No, it does not. But speaking of water breaking, outside of a external cephalic version, patient is within our care, perhaps. Oh, I think my water broke. What are you gonna do?
Well, I want to make sure that it did break. Let's see if there's anything leaking, and if it is, what's the color? Color's big, right? We gotta look at the color. Usually it should be clear. Sometimes it's like a little pale yellow tint to it, but like clear is what I want.
Is it amniotic fluid or urine?
Yeah. Ideally, should be clear. So we want to look at the color, okay? Let it be clear. If not, you gotta look at other problems. We'll talk about that in a second. But I also want to look if there's an odor. Look at the amount. Is it a lot of leakage, right? And you want to know the time. Time is big.
Oh yes, we talked about clock starts ticking.
Yeah.
When that water breaks. We don't want the longer the womb is open to the mean, cruel outside world, the more risk for infection, right?
Yeah.
We're going to be keeping our vaginal exams to a minimum with ruptured membranes too, because again, outside world, bringing it inside to an open womb.
Yeah.
Not a good idea.
Don't give an infection to the womb mate.
The womb mate does not like.
So minimize
not like that.
Those vaginal exams, and you got to keep an eye on mom's temperature too. because a lot of times if they develop an infection, so choreo is what
Chorioamnionitis.
yeah, so usually one of the things you'll see is mom will develop a temp, elevated temp in labor, and it's quick.
Is
It's
it?
quick a lot of times. Temp, mom might be tachycardic. And then I also noticed fetal tachycardia
Yeah,
too.
the baby gets, that the fetal heart rate might
So,
go above the normal baseline.
yeah,
That's chorioamnionitis.
yeah.
What would you do for that? Antibiotics or C-section?
Well,
It depends, huh?
depends on what the provider wants, but a little bit of both.
A little bit of
Definitely
both.
a little bit of both, probably.
Definitely try to
Yeah.
treat the infection.
Yeah,
Well, actually, I mean, honestly, try to avoid the infection.
Yeah.
Which is what we were just saying, how minimizing things as best we can.
yeah.
Um,
Also want to look at that fetal heart rate if she truly is ruptured. Want to see what that
Mhm.
baby's doing, how it's
Definitely.
handling losing some of that
Alright,
fluid. Is that the
alright.
baby's cushion?
That is the baby's cushion, so we do have to check the fetal heart rate. Back in the day, and I think we still do it in some places, sometimes it's not obvious. Sometimes you're thinking, well, of course I'm gonna know when my water breaks. It's gonna be this big gush of fluid, and I'm obviously not peeing. Well, sometimes it's not obvious. Sometimes there is a slight yellow tint to it. So even if it was out like onto the white floor, it might, like, is that urine or is that amniotic fluid? There's different tests that like they send off to the lab and pay millions for.
Yeah.
But there's this one fairly primitive test that is still, first of all, amniotic fluid is alkaline. With that in mind, what do we
Yeah.
do?
So we could do the nitrazine test. So pretty much we're checking the fluid's pH. And if it turns blue,
A
that is
nice rich blue, indigo
Yeah.
blue.
nice blue, like one of your stones over there. You have a stone
Mhm.
there that's like
Yeah,
blue, red.
yeah.
Yeah. And that usually indicates that it could be truly amniotic fluid and the patient has ruptured. However, one thing to be on the lookout for is any blood or like bloody discharge because that can cause a false positive. But if
Okay.
there's like just clear fluid coming out or like yellow fluid coming out, pale yellow, and you do the nitrogen test, if it turns blue, you can know that
All right. So
Yeah.
blue, most likely amniotic fluid because it's alkaline. Urine is not alkaline, and will not turn that nitrazine paper
Yeah.
to blue. You guys all remember nitrazine paper for one of your science labs, I think, right?
Yeah, your
Yeah.
pH paper.
It might still happen in whatever hospital that you are finding yourself in. So that's kind of a cool thing to know about. Pretty
Yeah.
low tech approach to, is it your water breaking or is it not?
Yeah.
Um,
So
We've
yeah, those
covered
type of
it.
things we look
Covered it.
at.
I think we've
Can we
covered
just
it.
talk about color really quick? 'Cause color is
Please.
important of amniotic
Color of,
fluid,
oh,
right?
the amniotic fluid.
We
Tell me
talk about
that.
clear, but
Yeah.
it's not always clear. Sometimes there
not.
might be a little blood, right? Could be some issue with the placenta. That could be a little bit concerning. But my other concern would be if I notice like green, like a dark green or brown color.
We're talking pea soup. Sorry. Did I ruin pea soup for anyone?
Yeah,
It looked
yeah,
exactly like pea soup.
yeah. You're right. You're right. I never thought about it that way.
I've never seen chunks of ham coming out, but I have seen what looks
Ugh.
like pea soup.
I don't want pea soup anytime soon. But yeah, so instead of it's not peas that's causing that though.
No.
It's usually the baby's meconium, their first stool. So instead of waiting till they come out, they will have their first stool in utero, and that can stain the fluid, and that's gonna be
There's two issues with that. First and foremost, if a fetus is in distress, it sends off their vasovagal business and they poop. They release the poop. So when there's a lot of poop like that, we are assuming that the baby has had some hypoxic incidents. So that the baby is in distress. Step one, shoot, we have a baby who is in distress. Step two, we got to get the baby out. But we don't want them breathing in all of this poop either.
yeah. 'Cause
So,
that's not gonna go somewhere good.
yeah. So we're gonna be ready for a baby. We're gonna be ready. That, in fact, we should always be ready.
For a baby.
But we're gonna
But we
be
need
extra
support.
ready.
We
extra
got
ready.
a lot of support. Neonatal team, be prepared for resuscitation.
because that baby was under distress. We're gonna try to make sure that it doesn't breathe in all that gross,
Yeah.
thick meconium pea soup, if you will.
Yeah.
And that distress may follow them out. Yeah, so full
Yeah.
resuscitation
Full
team,
resuscitation, be prepared.
present,
Yeah.
at the birth if at all possible.
Yep, definitely want that, cause you know, poop in the lungs, airway, we don't want that.
No, no.
Have
If
the
we can-
specialist there.
If we can avoid it, we will.
Yeah.
Absolutely will. Yeah, so that's no joke.
Yeah.
In order to get that kid out, we need to have contractions, right?
Yeah, ideally, that's your power,
That's the
right? The P's of labor, power,
Mhm.
that's your contraction, so.
We have spontaneous labor that may be augmented with Pitocin,
So.
or we have
Enhance it
inductions, which is also
with
Pitocin.
Pitocin, yeah, or cervical ripening, if that, you have that low Bishop score,
Well, that's true, that's true. So
but not always medications.
it's not always medications. It could be some sort of prying
Okay.
open of the cervix. But I gotta say that sometimes it's too much, right? Sometimes we can give
Sometimes
too
you give
much.
too much, yeah, especially with Pitocin, you gotta be careful, cause you can cause tachysystole.
What a word, huh? Let's
Tachysystole.
try to weave that word into
Mhm.
your Thanksgiving Day conversation. What about tachysystole?
Yeah.
I might, because I'm working on Thanksgiving.
Ooh.
So I might actually use the word tachysystole on Thanksgiving.
Okay.
Let's see what you can do at home. Yeah, so on that one.
Okay.
Tachysystole is what? Like one big contraction that won't let go?
Yeah, no, pretty much a lot of contractions.
Boom, boom,
More
boom,
than
boom.
5 in a 10-minute segment. More than
Okay, that would
minutes.
be considered tachysystole. I
Yeah.
guess that makes sense. And what's the big deal? Well, the big deal is nobody's getting any rest.
Yeah.
And nobody's getting any oxygen. That uterine muscle is contracted and not allowing for enough rest and dilation of those blood vessels,
Yeah.
right, to re-oxygenate not just the muscle, but the placenta and baby.
Yeah, so placental perfusion, oxygen, oxygen, that's an issue,
It's an
so.
issue.
they
And
need
it's
a
also
break.
quite overwhelming for the birthing parent.
Yeah, and we talk about, like, we want moms to rest in between contractions, so why are we not giving them a break?
So what would happen, obviously, if we're the ones causing the contractions with like Pitocin,
Mhm.
it's a very powerful drug. Those oxytocin receptors are super, super sensitive at the labor time. So we give just a whiff of it, and sometimes some
moms
patients are,
Contraction.
yeah.
Contraction.
So what are we gonna do in a case like
Well,
that?
we're gonna fix the problem, the cause, which we're gonna reverse it, stop the cause.
So
Turn
stop
it.
turn the pit off.
Turn off the
All
pit. If
right.
it's causing tachysystole, stop it.
What happens if we're not causing the contractions, or maybe if we are? Is there like an antidote to
Yeah,
Pitocin?
there's sometimes you could give tocolytics.
Tocolytic.
Yeah, fancy word. Tachysystole and tocolytics, all T's.
Mm,
P's and T's in labor.
P's and T's. So tocolytics.
Tocolytics
they're-
gonna stop those contractions.
That's we're gonna try to give that
We're
to
gonna try
stop
to do, yeah.
contractions. What drugs would be considered tocolytics?
For in general.
In
You
general.
talk about just in general. So you have mag sulfate.
Smooth muscle relaxer.
Yeah, you have terbutaline,
Terbutaline, common drug.
nifedipine.
I thought nifedipine was a blood pressure med.
It is, but it's also used to stop those contractions. So we can give that oral nifedipine. Biggest thing though is you got to keep an eye on that blood pressure.
Yeah.
Even like with mag, right? Think about it. Magnesium, we use it for preeclamptic.
Hmm.
And we use it, and we'll talk about this, preterm labor as well is another thing, but it's gonna stop that, but it can also lower that blood pressure, so be mindful of that.
So we got some things we're gonna do, but more than if we're causing the contractions with Pitocin, we are being very, very careful and increasing it just small amounts. We have a protocol. We are monitoring the contractions with an external fetal monitor. And the external fetal monitor is measuring, if I'm not mistaken, it's measuring our duration of a contraction,
So how long
our
it lasts,
frequency of a contraction,
how often they're occurring in
and
minutes,
strength.
and strength, not an external monitor.
Not-
External monitors for contraction, so your external toco transducer cannot measure the intensity.
Oh,
you would need an internal for that, an IUPC.
Intrauterine pressure catheter.
Yeah, so that has to be inserted as long as mom's ruptured. That can be inserted, and that can measure the frequency, the duration, and the intensity.
All right, so an external monitor cannot measure strength.
Yes,
Internal monitor
Can.
will.
but both will do frequency and duration.
Yeah, that makes sense too, because it's monitoring
Yeah.
the pressure,
Yeah.
intrauterine pressure.
There you go.
All right, all right.
IUPC. But yeah, the external can't. That's all based on palpation. So you actually have to feel as a nurse the abdomen when a mom is having a contraction.
Uh-huh.
And so one of the tricks we do is like feel the nose. And
Nose,
that's like mild contraction. That's
Mild.
that when you push down, it feels like that, softer.
okay.
Your chin is moderate. So a little bit like
Oh,
harder. Right?
yeah.
And your forehead, nice and
Oh.
hard. That's a strong contraction. So that's how we
Mild to palpation, moderate to palpation, strong to
Yeah.
palpation. And that's how the
we kind of determine
uterus
it.
feels with our fingers, mild, moderate, strong.
Yeah,
Strong, strong, strong.
Yeah.
All right,
that's kind of what we do.
that's good to know.
Yeah. So
Good to know.
all those things for measuring contractions, but
It's
there's-
funny. You put your hands on a belly. What do we got here? Holding one hand on the
question,
belly.
though. I don't know if a patient would question it. So there's so much going on that they don't even realize what's going on. But
So that would be another way. The other, if we're talking about monitoring for a minute, so we have the Toco transducer, the external monitor that monitors contractions, obviously frequency and duration, not strength.
yeah,
Then you have the fetal heart rate, or the ultrasound
Yeah.
one.
that's for the baby.
That's for the baby's heart
Yeah,
rate.
because usually external monitors, there's two. We
Mhm.
have one for the contractions, and that's usually going to be placed on the fundus,
Okay,
the fun part of the uterus, the upper part of the abdomen, and then we will place the ultrasound for the fetal heart rate. Usually that's on the lower part of the abdomen, ideally.
well, if they're head down.
If they're head down, it's
Okay.
usually on the lower part, but the best location is going to be along the fetal back.
So if we can do
Yeah.
that whole
Leopold's
Leopold's
maneuver.
maneuvers, find the smooth back, we're going towards the baby's back
Yeah,
and the head. So it's on, if the head is down, it's gonna be on the lower belly towards the baby's back.
yeah,
Alright,
that's what we want to do. They get it there.
that's good. Ooh, man, that's the only way that baby's talking to us. That's the only way that baby is talking to us. So there's things we gotta do. There's things we
There's
have
a
to
lot we
do.
have to do.
And
That's why
that
you're
is the-
one-on-one in labor. That's our telly.
Yeah.
So
yeah.
that's our telly. We don't-
And
what's going on.
that is our second patient is talking to us through their heartbeat.
Yeah,
So we are monitoring, it's not just a squiggly line to us, it's that fetus telling us how they're doing.
yeah,
So we are taking a quick look, we'll get the patient there, we put them on the monitor, what are we doing?
we're looking at their obviously contractions, but for the fetal heart rate, you got to look at your baseline first.
Baseline
Ideally,
first.
110 to 160 is where we want that baby to hang out. Okay, so we figure out where they're hanging out. Okay,
We check their baseline.
baseline first.
Okay.
Then we do variability. So there's different types of variability. I like to describe that as like, so that's a fluctuation in heart rates, but it's like the scribbliness, right? There's 4 types. There's absent, that's not good. There's minimal, moderate, and marked. Marked also not so good. Our goal is moderate. That's what we want.
So it's like how
Okay.
squiggly the line is, okay?
That's
Yeah.
one way to remember it. Okay, so we want
That's
to be
called variability. you said.
variability.
All right.
Okay.
So baseline and variability.
Yes, and so we want to get to moderate. Minimal is okay. Sometimes that can mean that like the baby's in a sleep cycle, or if we give mom some meds, that's all right. But if there is minimal variability or absent or marked, usually we want to correct it. Unless
Okay.
the baby's in a sleep cycle or you just gave mom some meds.
Okay, so could be that, and we'll wait a little while perhaps, and if it's still minimal, then we might start
Something.
something figuring out.
Yeah, what's causing it? Yeah,
Yeah.
some fetal scalp. That's what you do. Fetal scalps. And you guys know what that is? Stimulate the scalp to cause an acceleration.
So we would do a vaginal exam, and if it's baby's head down, we'd
Tickle,
just like rub the baby's head and kind of like try to wake the baby up a
Yeah.
little bit. Gotta be careful, can't do it too much, but
Don't get them too excited, but
well,
see an
because it could
acceleration.
actually cause a
Mhm.
fetal bradycardia. overstimulation. But anyways, neither here nor there. We're gonna try to wake the baby up,
Yeah.
see if the babies have that minimal variability simply because they're sleeping.
Yep, and that's what we do.
Mhm.
And then we have to look at the presence of accelerations, which we just kind of mentioned, which is pretty much like these nice mountains. It accelerates from that baseline.
Well, that's why we need to know what the baseline is.
That's why you need to know the baseline
All
before
right.
you can look at the presence of accelerations or presence of or absence of decelerations.
Decelerations. Now, there's a few different kinds of decelerations, and we do expect for you to be able to recognize the different decelerations.
Yes.
I think the easiest one to recognize is the jagged, like either U-shaped, V-shaped deceleration. It goes down abruptly, hangs out, and then abruptly returns to baseline.
Yeah.
U-shaped, because it looks like a capital U,
Yeah.
or V-shaped, either way, V for variable. That's
The
a
biggest thing
variable
is that they are
deceleration.
abrupt.
Abrupt.
They
Sink down.
quickly happen, get to the lowest point pretty quickly. And they can happen with or without contractions too. That's the other thing. So even if you don't have contractions, you can still have variables.
Variable deceleration simply means cord compression.
Cord compression.
So it could be
babies are
from a
constantly
contraction,
moving,
it could be just from baby
Yeah.
leaning, rolling over onto their cord.
ideally. And so a lot of times if you see that, you're gonna wanna, if it's recurrent, keeps happening, you wanna reposition them. 'Cause sometimes babies might sit on their cord or something.
Mhm.
So that's gonna be what you wanna do for that.
All right, then you got the
Mhm.
other two kinds of decelerations. You have the early decelerations
Yep.
and late decelerations. And quite frankly, they look pretty much the same
Yes.
if you're just looking at the fetal heart rate.
That's why you gotta look at the contractions, because they're dependent on the contraction.
Oh, that's the big deal. So both earlies and lates, you need to look to see when they're happening in relation to the contractions. Early decelerations kind of mirror basically
Exactly.
the contractions. So as the contractions going up and peaking and then coming back down, the fetal heart rate's subtly dropping.
Yeah.
And at its lowest is pretty much at the peak of
Yeah.
the
I
contraction.
don't know if I could do this. Like this is coming down.
Wow, look at you. Wow, that's
backwards.
very good.
Yeah.
That is very
It's gonna
good.
be what I show everyone at Thanksgiving for talent.
Oh,
New skills I've developed.
absolutely. So mirroring the contraction happening during the contraction,
Yeah.
basically, this early deceleration. Rushing to the OR for that or what?
Absolutely not. No.
What-
So earlies is usually going to be caused by head compression. So
Squeeze of the head,
yeah, squeezing that head. Okay. Where we see this usually is actually when mom is like
ready to.
in active phase, like ready to push out a baby. She's probably fully dilated or close to it. That head is engaged. So we don't have to do any interventions for earlies. We actually like earlies. It's kind of reassuring
yeah,
that
like,
we're
ooh, 'cause
progressing
we're
in labor.
progressing
We're
along.
hitting that active phase.
So early deceleration's benign, nothing to do with it.
Yeah.
Just maybe check her if she's comfortable
Yeah.
in sleeping or whatever. Let her be whatever, but nothing. We don't have to do anything with
Yeah,
them.
I've had people where I've like put them on. It was usually my pre-sip deliveries.
Yeah.
Like I put them on the monitor and it's just like early, and I'm like,
Yeah.
you're about to have a baby.
We're having
Yeah,
a baby.
it's like when they say like to like the baby's head's right there, they're crowning, or like I gotta poop, I have to go to the bathroom. I'm like, earlies, you gotta poop. You're about to have this baby. I gotta get ready for delivery.
Oh, we talked about anyone they feel like they have to poop. Sometimes they actually do poop.
They
and
do,
that's
but we don't tell them.
No,
I told my class,
no,
you don't
try
tell
not to tell them. You have to be subtle about just.
Yeah, the air freshener.
But also, sometimes there's nothing you can do to convince them that they don't have to poop because because the head is coming down, the rectum's like pressed shut, so it feels full,
Yeah.
but it's actually just flattened. Either way, if you have a patient saying, I feel like I have to poop,
You've been prepared for delivery.
Get
ready. You check.
Don't say, well, go on ahead, because I don't want you pooping in the bed
Yeah,
later.
and if they're
Go on ahead and push on the toilet. No,
Yeah.
nope.
No, don't get them to the bathroom. Get ready for delivery. And
All right,
if you
so
check and there's a head there.
So that's early decels, but so the late decels, same thing? Is that a head?
No, so lates are usually happening after that peak of the contraction. So it's also coming down from baseline, but that's usually related to uteroplacental insufficiency.
Okay, so after the
with the
peak of the
uterus.
contraction, that's when the late
Yeah,
deceleration.
so right.
starts.
So like we're
Here
still
we
up
go.
here and then now we're coming down.
All right, so
Ooh.
the late deceleration happens later.
Yeah,
That's
it's late to the party.
late to the party after the peak of the contraction.
Yeah,
You're saying that is placental insufficiency?
utero insufficiency. So it could be an issue. Usually though with the placenta or uterus, we've got a problem there.
We have a problem there. That's a
And
baby
that's
who's
that
saying, you know
baby's
what?
lifeline,
I
right?
cannot, I have no backup. And that contraction just stressed me out
Yeah,
to the point where I need to drop my heartbeat because I don't have enough oxygen.
no.
So a late deceleration, trouble.
Yeah, we gotta do something.
Did
And
you talk about veal chop?
I did talk about veal chop.
It's a
Yeah.
good way to remember our
Yeah.
contractions
Yeah. So
or our
decel
decels.
and accelerations, because
Mhm.
we never forget about accelerations. Accelerations, we like to see them if they're absent, not the end of the world, but we do like to see acceleration
They're
because that means
reassuring.
fetal well-being, right? They're reassuring. Central nervous system's working. It's the decels. We really have to keep an eye on what they mean.
So V for
Is
is variable, and that is connected to the C.
I'm the C,
Fourth.
she's the B.
All right. E,
E is I don't know how to do an H. Head
head
compression.
compression. Acceleration, that's A for veal.
Okay.
Okay. And then there's L for late. Gosh, here we go.
Utero.
Or P for chop.
Oh yeah, placental utero insufficiency. Yeah, placenta.
So the placenta is, or
Mhm.
uterus is
Uterus,
ain't
yeah.
working right.
Placentas is an
Right?
issue.
So veal chop, well, that was very awkward. What we just did was very awkward.
P.
P for placenta.
I was
Um,
prepared to do this
P for
acting.
not prepared.
Yeah, that's an issue. We gotta do something though. You better intervene.
So, all right, that's
You intervene
babies
for
asking.
variables and lates.
That's a baby asking for help.
Yeah.
And that's even more urgent than possibly the variable, but either way,
Yeah.
you need to do something for
Yeah.
both of those cases.
Yeah, especially if they keep happening. Because variables, like sometimes it's just a blip, no big deal. Just reposition, move around.
Yeah.
But lates, we've got to reposition mom.
Intrauterine resuscitation.
Yeah.
Intrauterine
Resuscitate inside.
resuscitation, step one, stop the stress.
Yeah. If they're on Pitocin or something, we got to turn that off.
Okay.
That's if they're on it, right?
Mhm.
Always turn it off. People forget that because they always learn about everything
Well,
else.
we know
Turn
that
it off.
contraction constricts blood vessels. Stop the stress.
Yeah.
Okay, so stop the pit if they're on pit. Reposition mom. What we're trying to do is increase volume / oxygen
Yeah.
to the baby, but we can't get to the baby, so we have to go through
Through mom.
Stop the stress.
Yeah, she's the middleman. Reposition.
Reposition may help
Perfusion.
increase the perfusion to the uterus /
Yeah.
placenta / baby.
Yeah. Then IV fluids too help.
Volume. So increase if
Volume,
mom is
bolus.
low on volume, then we need to increase mom's volume, which would then maybe increase volume to baby.
Yeah.
If mom is low on oxygen, then oxygen is still
Yeah.
considered
Oh, absolutely.
part of intrauterine
Yeah.
resuscitation.
10 liters non-rebreather. Fill up that bag, stick it on her. It doesn't hurt. Even if her O2 sat is like 95, you know what? Put it on.
If would get moms as oxygenated as possible so that what is getting to the baby is as oxygenated as possible.
Yeah.
So that's called intrauterine resuscitation, doing all of those things.
Yeah.
Stop the pit, reposition mom, fluid bolus, oxygen. All the provider.
Yeah, that's important. I guess you might want your physician
I mean,
there.
honestly,
Like,
you might be calling out of the room while you're doing all these other things. Say, hey, can you get Dr. So and so in here? We were having
Don't leave the
having a-
patient.
don't run screaming out of the room.
Yeah.
We definitely need to get people involved
Yeah.
on this one. That doesn't necessarily, I mean, if we do all those things, it might work. But the baby's telling us things aren't good. So it's going to be a delicate balance of causing stress to try to progress labor and stressing the kid out too much.
Yeah. And if those things don't work, then you got to look at possible C-section.
Possible C-section. All right. Pain management. So, this is, I was talking today about how when we're doing an induction and when a patient complains like, oh, this is starting to really hurt, our first instinct is to say,
You
oh,
want that
good. Oh,
one?
good, because we're trying to induce labor and we know that as labor progresses, the contractions
Should
get
be
longer,
painful.
stronger, closer together, right?
True
And more
labor.
painful. The problem is it's
True labor contractions are gonna be painful, especially as you're doing some form of dilation,
right.
cervical change, right?
True
As you
labor
dilate.
changes the cervix.
True labor should change your cervix. If it's not changing the cervix, it's not real
It
labor.
ain't happening.
It ain't
All
happening.
right, good to know. Good to
Yeah.
know. So vaginal exam actually is actually a big part of
Confirming.
assessing the patient.
Yeah.
Are they in labor or are they not?
Yeah.
Yes. True labor changes the cervix.
That's true.
All right. Okay, so say it is true labor.
True labor is true.
They're
And they're gonna want to manage that pain because it hurts. Some people
Mhm.
want to manage it with pain medicine,
Um,
pharmacological interventions. Others don't.
yeah, there's different things. Anything systemic, like a drug pushed into an IV or something like that, will get to the baby. So we gotta be mindful of that, but sometimes
Yeah.
that's all they need is just enough to kind of relax a little bit.
Yeah.
But we need to be mindful of the baby too. I was talking in my class about how we might give, the timing is important. We give that drug
Absolutely.
when they're actively asking for it, it's usually probably too late.
Yeah, so you can't get a medication if you're 9 centimeters or,
Because that baby's gonna be
fully
born at the
dilated.
peak of the med and
Yeah, and
will
that
not
could
breathe
cause,
for us,
yeah,
which is tough.
respiratory
Mhm.
depression in that
I gotta tell
infant.
you, one of I think the most effective um, pharmacological pain management technique is an epidural.
Yeah,
I like epidurals. It's kind of scary for a lot of people to think of. And it does have its risk by all means. Um, but an epidural very well might allow for the relaxation of the rest of the body. And
Mm.
it's not without its risk though. So let's talk a little bit about
Yeah,
the number one. I would almost call it a side effect, but it is considered an adverse effect
yeah.
of epidurals is
Hypotension.
hypotension.
Pressure drops, tank.
And man, it does tank.
Yeah.
And you know what happens then? Blood pressure drops. They get all like, ooh, woozy. I mean, like they literally are like, oh gosh, I don't feel good. Guess
Not
who
just
else?
her.
Guess who else tanks?
That baby.
That baby. The
Yeah.
baby tanks too. So we got
Yeah.
a bradycardia, which is any fetal heart rate, lower than baseline for more than 10 minutes or 2 minutes or
Yeah.
whatever the hell it is. A long time. We're not
10
gonna wait for the 10-minute mark, but
minutes.
Huh?
Yeah, 10 minutes.
Yeah.
Baseline change. Yeah.
Yeah.
Yeah, they just drop. Yeah. So we
Yeah.
got to correct that. How do you correct hypotension?
Well, I don't know about you, but I'm going to,
Fluid.
I'm going to increase the fluid. Most I know in my facility, the anesthesiologists like literally hang out and wait.
Yeah.
For at least the first 15
We check
minutes.
blood pressure like every minute.
Yeah.
Or like the
But the
first 15 minutes.
anesthesiologist is like
So every, like, 1
waiting
to 3
around,
minutes.
waiting for this blood pressure to
Yeah.
tank because we'll give them some epinephrine.
Yeah. And we will always bolus our patient before we even give them the epidural.
Mhm.
Don't give any anesthesia until you've at least gotten a bolus in them, a liter in them.
A liter, 500
Because
milliliters,
that will
some people
help.
will say, but yeah,
Yeah.
get it out.
Get fluids in them to help prevent that hypotension.
Right, and if anesthesia walked away too far, you grab them back in there
That's it.
and
They come back and they'll
yeah.
give
and then they take care of
their meds, their bolus, everything.
the
Yeah.
business. Then there's we were talking in my class, we had a situation at my clinical where the patient's grandmother was a massage therapist and
Mm.
pressed done some magic spots and really, really helped the patient relax, which was amazing.
Oh, there's so many things you can do.
There are some really cool things.
Yeah.
There's some really cool things. And I've seen people work really hard at preparing ahead of time.
Yeah.
They have got breathing like rhythmic breathing,
Yeah.
not breathing too fast, not breathing too slow, not holding their breath, but breathe, like concentrating and distracting themselves
From
by
their
breathing
contraction
in
pain.
and breathing out. Keeping that
Relaxing.
as best as possible. There's aromatherapy.
Oh yeah, we use that a lot.
Do you?
Yeah.
Aromatherapy, like lavender,
Peppermint.
yep. Guided imagery, as some
Yeah.
of you may be taking guided imagery or
Yeah.
I don't know if that
Oh,
was
yeah.
offered to you.
And even music, certain like relaxation, like
Get a lot of people who like just hydrotherapy or warm,
yeah, water,
getting into
the
the,
shower,
yes.
even
the
birthing
water.
tubs. Like some patients will even like labor in a tub and then they come out as they're in active labor,
There's
ready
a
to
hospital,
push.
there's a couple of hospitals here that they can actually deliver in a tub.
Yeah,
Um,
yeah. So there's
either way, that really
even
helps
like
a lot of people.
back pain, like putting pressure on that lower back, especially if baby's OP, or warm compresses on
Warm
that back.
Yep, sacral counter pressure
Yeah.
perhaps. And there's a lot of non-pharmacological techniques that might be all a patient uses to get through,
Yeah.
or it may be something that complements pharmacological
Yeah,
stuff or
absolutely.
gets them to a point where they are eligible for um some sort of other intervention, more
Yeah.
medically focused.
Absolutely.
All right, so we've gotten through all of
Labor.
this stuff. They're pushing out a baby. There are some complications that I
Yeah.
think we probably need to talk about overall. But I mean, then when I'm thinking about like going through the stages, the pushing phase, again, we want relaxation, rest between contractions to gather strength and reoxygenate by all means. Sometimes, sometimes they just aren't getting that baby out.
Yeah, so we have to do something,
Yeah.
right?
Um, so sometimes providers want to kind of pull on the baby while the baby is while the birthing parent is pushing,
Pushing.
the provider wants to pull. There's a couple things we can do, forceps, which are very
Forceps, yeah. So
with the vacuum extraction.
like the salad tongs that grab around the head to push that baby
I'm
out.
so glad I put the brain there.
Yeah, this worked out nicely. All right, or you can also do the vacuum.
The vacuum, it's like a big
Suction.
suction cup. Yeah. The problem with this, the problem with this one, and I touched upon this a little bit in class today. We might be pulling on a head that's really not meant to fit out. So the head needs to be making a pretty good effort to come out. So it needs to be low enough in
Oh,
the
yeah.
pelvis that gives us a better indication that it's actually going to fit. All right.
It's gotta be at a low
At
station.
low station. What would you say the station should be?
+2.
So, all right.
Ideally +3, but who am I? At
Right.
least
So we need it below the ischial spines.
Yeah.
If the provider is like saying, "Oh, give me the such and such, give me the vacuum," and I'm like, "Hold on a minute, time out." Like we're at -2 station. This baby has not told me that it can fit out of that pelvis
Yeah.
yet. So this might be a time to really advocate for your patient. You definitely want that head low in the pelvis, which would indicate a better chance that it's actually fitting out of the pelvis.
Yeah.
You start pulling on a head that's not supposed to fit out, and we're gonna have trouble. We're gonna have trouble.
Exactly.
There's some other things that might come out.
Oh.
Oh yeah, things like that, like mirrors. The umbilical cord, we call that prolapse cord when especially like if their water breaks and the head was not like well placed, the cork wasn't in the bottle basically. They might, the umbilical cord can kind of come down ahead of time, and then all of a sudden the head comes down and presses, causing
Compression.
cord compression, which might
It's gonna be a
cause
consistent
variable deceleration or just constant down low
Yes, thank you.
bradycardia.
We don't want that.
Needless to say, what happens with the cord prolapse? Can you just like push it out of the way and start
If
pushing?
only, if only.
If only.
You gotta,
I mean,
well, you should have a sterile glove to know that it's a cord. Sometimes you
Yeah.
see it, sometimes you'll
Oh.
feel it during a vaginal exam. Ideally, you already have a sterile glove. And you gotta pretty much put that pressure on the baby's head to literally push it up. So it's not putting pressure on that cord. So one time I had, my class knows this, I had my first cord prolapse and I literally had to go with the patient on her bed, laying down,
Mhm.
rush to the OR with my 2 fingers inside, putting pressure on that fetal head. We put her in Trendelenburg. And then, so
using
here I am
gravity?
like this, using gravity to release some of that pressure. And then I'm putting the pressure with my 2 very giant fingers, as you can tell, trying to push that baby's head off of that cord so it didn't have compression. great time.
Great time and,
Then I got draped and
oh,
everything. It
yeah.
was fun. But
I've
that baby was
taken-
out and it did well.
Yeah, I've taken many a ride, in the labor bed,
Yeah.
with the butt up in the air or something like that.
Yeah.
Keeping the head off a cord as best as possible. So we don't leave. We're in there. We press that head. Try not to touch the cord because we don't want to like damage the cord. But sometimes it's on either side of the cord, and the cord is between. You're just trying to push the head up off the cord.
Yeah.
Um,
Until you
That's-
get that baby
that's
out.
rough stuff. Let's talk a minute. Let's step back, if you will, and talk a minute about preterm labor.
Okay.
So, we have, that's one of the complications we talked about, I'm sure. When a patient goes into preterm labor, um, like before the 37-week mark,
Yeah.
what kind of things, I mean, are we just gonna say, well, that's too bad, here we go?
Yeah, no. I mean, if you're like 36 weeks or something, yeah, here we go. You're gonna have that baby, no big deal. But like you think about like those early preterms, like especially before like 34, 35 weeks, right? But especially 34, we want to stop it if we can.
Okay.
So that's where tocolytics
Oh,
come back.
tocolytics.
They're back.
Oh.
And this is where we're using max sulfate.
Okay.
For sure. Max sulfate's gonna help stop those contractions. It also helps with neurodevelopment for preterm babies, so it's kind of like a win-win. So you have your max sulfate. You also have your nifedipine.
Mhm.
You also have terbutaline here. Yes,
Those are the main ones, I
Yeah.
would say, yep. What other medicine are we giving to mom if we anticipate preterm birth?
Celestone.
Yep, Celestone, betamethasone.
Betamethasone.
It's a
IM
corticosteroid.
injection. Corticosteroid, not so much for mom, but this is more for baby. So under 35 weeks, their lungs aren't really that well developed. And so that Celestone is going to help with that surfactant. So that way it prevents lung collapsing. So we're going to give 2 doses, IM injections, ideally 24 hours apart. if we can.
Studies show that even one dose may actually decrease the incidence of other preterm complications like necrotizing
That's awesome.
enterocolitis. Yeah, so even if it's one dose, it very well might help that premature baby.
Anything.
But it will, the Celestone, betamethasone, corticosteroid, whatever, Celestone is a brand name by all means.
Yeah.
All of the same thing that steroid hastens or quickens fetal lung maturity. Was that you or me?
Great.
'Cause, yeah, me too.
Yeah.
All right, so those are some things we're gonna do to
Sound
try to,
like,
we're gonna try to stop the labor, but if we can't, we gotta get the
Exactly.
baby ready to breathe if possible.
Yeah. Since we're talking about like other med save mom, can we just talk about antibiotics, Pen-G for GBS?
Absolutely.
So for
Absolutely.
beta strep,
So group B strep positive
positive moms are gonna need that
antibiotic.
antibiotic prophylactically. Not so much for mom. So if she tests positive for group beta strep, no big deal.
We're
for
not gonna
mom.
treat it
More
like-
so for
We're not gonna treat it before she's in labor.
yeah, but that's really while she's in labor, we want to give her antibiotics.
The goal is to give it to her IV and a pretty good amount too, might I add. The goal is, the reason why I give it in such a good amount is because what, about 5% actually passes through the placenta and gets the baby. So our goal is to go through mom and arm the baby with antibiotics before coming through the chute. All right.
Yeah.
So give
especially
mom
vaginal
IV
deliveries.
antibiotic. What's this?
Especially the vaginal deliveries. That's really
Yes.
C-section.
Not so much with the C-sections, but we want to give mom IV antibiotics that are sensitive to this group beta strep. So
Yeah.
penicillin G is the number one, but if they're allergic to penicillin, we're doing a
Just put them in.
sensitivity thing. Yeah.
Yeah. Give
and-
antibiotics.
Antibiotics IV to mom in enough time so that it crosses the placenta and gets to the baby. So the baby's armed with antibiotics before coming through the chute.
Yeah. Because otherwise they're at increased risk of sepsis and we want to avoid that at all costs.
do
So
not
we
want
try
that.
to get adequate treatment before the baby is born.
All right, very
Comes out of
good.
the chute.
Comes
Don't wait. Explain labor. I mean, you can make it prettier, at least. It's
It is a beautiful
thing.
thing. It is beautiful, but come on.
Baby's
Come
coming
through-
out through
Come on.
mom's vagina and breaking everything. Yeah, no, it's
Oof.
beautiful.
Beautiful. You know what? Sometimes, if talking about breaking, there's there's two nightmare scenarios. And I have to say them, but and I know we talked about it in class today.
One's baby, one's mom, huh? I can see where this is going.
Yeah, kinda. One is when the head comes out and gets stuck. Here we go.
Here we go.
We got the head comes out, and then we
Head's
have
out.
the turtle sign.
Oh,
Turtle sign.
little turtle suffocating.
Yeah. All right.
No
Shoulders are
oxygen.
stuck. Yeah. Right. We got to do a couple of things. Our
Let's
goal
lose
is
it.
to widen the pelvic arch, open up the pelvic arch. McRoberts maneuver, hyperflex those knees up and actually point them inward.
To help
open up the pelvic opening is as wide can be. The other thing we're gonna do is suprapubic pressure towards on the baby's
She's
back.
nice. She does it like this. I do it like that.
Oh, however,
Sucker
yeah,
punch.
however it is, what we're trying to do is we're actually trying to push
Yeah,
the
hit that
shoulder
shoulder.
down and if we can slightly rotate it.
Yeah.
That's why we're
So that way
we're
we
gonna
can
do
get
it
the whole body.
under-
I'm not gonna show you my shoulder because that's risque, but like
so
that
that's exactly what
super
we're trying to
pubic
do.
shoulder, so
Yeah.
it's like coming out.
Yeah, so we're trying to push it down so that it comes out, and so we're literally trying to unwedge it from
Yeah.
the thing. There's some things that the provider is doing, provided the provider is there. And that's like the wood screw maneuver, which is trying to rotate the head, which will hopefully rotate the shoulders
Yeah.
and try to come out from underneath. They may also deliver the posterior arm that might
Little
drop
disco
them.
baby.
Yeah, a little. And if none of
Yeah.
those things work, unfortunately, we have to push the baby back in and go by C-section.
Yeah.
And I myself in 35 years have never had to do that. Have you?
I have. Just
You
once.
have, yeah.
Yeah, over 2 minute shoulder. It was like almost a 3 minute
Yeah,
shoulder.
absolutely
That
ridiculous.
C-section. A lot of times they will try to do an appease before we go to the
Yeah.
OR.
You fight the urge to want to just like push on the whole belly, which is absolutely not called
Don't
for.
do it.
That suprapubic pressure.
Yeah.
However,
You're trying to
it
get
is.
the shoulders.
Yeah, it's
Right.
not the whole baby, it's the shoulder.
Yeah, unfortunately, that
Mhm.
can cause a fracture, clavicular fracture on the infant. But it's
Mhm.
one of those things like, do you want to cut off oxygen or do you want to?
Right, so we're checking all babies because it's not just the
Every
shoulders,
single
like when we're doing our assessments, we are checking the clavicles for fracture anyways. And they're more likely to occur, definitely.
In a shoulder baby.
In a shoulder.
Yeah, shoulder baby.
The other nightmare scenario, which I have seen a handful of times, is a uterine rupture.
Ugh.
Yeah, rough stuff. The patient I was telling my crew about this day was it came in the middle of the night. She was scheduled for a C-section. She did not report even having contractions, but she felt like she was ripping open.
Mhm.
Now, by the time she got to us, she was like in a catatonic state almost. She was eyes wide open, not blinking, in a like a fetal position herself, and just trembling,
Oh,
unable
gosh, I
to even speak. And it was her husband saying she didn't say she was having any contractions. She just woke me up and said that she felt like she was being ripped open, which indeed
It's
she
pain.
was.
It's just sharp pain.
Yeah, she was actually her uterine and scar from the previous C-section was completely wide open.
That was the same scenario I had. It was a previous like C-section, is a uterine scar.
Yep, the uterine scar wipes open. Now, the deal is with that, it's going to obviously pain. If the baby has like fallen out of the uterus with the opening, you can actually see like the abdomen's gonna look weird because like the baby's outside of the uterus.
Yeah.
So that's
not
weird.
no kind of
And
perfect
the
fit.
baby's probably not gonna like this new situation. All right, so there's gonna be,
If you're on the
fetal
monitor,
distress.
Yeah, if that happens
Definitely.
while she's on the monitor, that
Mhm.
baby's going down.
Yeah, major issues there all
Yeah.
around.
Agree.
Now, and I just need for people to know that not all uteruses that have been cut into will rupture. We have to be mindful in terms of VBAC. Candidates for VBAC will have that low transverse incision only. If they have a vertical incision, there's absolutely no possibility of VBAC for those patients. Because while easier to get into a uterus, doing a vertical incision, it does not heal well.
Yeah, no.
So we will not
That's usually after you've
participate.
had multiple
Yeah.
C-sections.
Yeah, so I mean, we've survived labor, we've survived pushing, we've survived all these things. And I know that we talked a lot about this early on in the normal newborn, but there are some complications, common complications of newborns, that we do need to consider, once they're out, things to be mindful of.
Yeah,
Now it can get really involved, and some of those chapters do, and some of those chapters are covered actually in your pediatrics class, all those cardiac defects and whatnot. And I know in my class, I did leave those PowerPoints up there for you to look at, but we're mostly concerned with kind of I don't know what, can I say normal newborn complications?
the
Nothing.
more common ones that
Okay,
you
so-
might see as an OB nurse.
So the first one, the baby who, based on their gestational age, is either small for gestational age, which would be defined as what?
SGA, like less
SGA.
than 10
The
percentile
less
for
than-
their weight.
So we have
because-
like an average weight
Yeah.
for a baby at whatever gestation there's.
Yeah, so you have to
Yeah.
know how many weeks they are when they're born.
Right. And so then if they are like way smaller than what we would expect for that gestation, they're considered small for gestational age.
Yeah.
And if they're way bigger,
So greater than 90th percentile.
they would be considered large
LGA.
for gestational age. All right.
Yeah.
So each of those scenarios, we are mindful of, well, first of all, why are they large or small? They're gonna have a little trouble with things like regulating their blood sugar.
Blood
That's probably
sugar
the
and
main,
temperature, yeah.
thing. Yeah, the main thing is hypoglycemia.
Glycemia,
Um,
blood sugar.
Yeah, and of course temperature regulation.
Yeah.
Yeah.
So with hypoglycemia, like you have to monitor their blood sugars frequently and before feeds, because we want to know how, if they're sustaining, right, their blood sugars without being fed. And so breastfeeding, they can be exclusively breastfeeding, but you just want to do it more often. So like maybe every 2 hours as opposed to every 2 to 3. Sometimes we do have to supplement with formula. Sometimes if
Formula,
breastfeeding is not
yep.
maintaining it, we will do formula, and certain scenarios too, we might do glucose gel.
Yeah, anything like that. And we're gonna check first on what their blood sugar is before we
Yeah.
would feed them. And while it might not necessarily be a question on an exam coming through, there are signs and symptoms of hypoglycemia, like that jitteriness,
Yeah,
this
jittering.
high pitched kind of shrill cry. Those are two main ones. The jitteriness. I think,
Jitteriness,
is the
I think, is the most
yeah,
common
yeah.
one, yeah.
They can't hold their temperature up either when they have a
Yeah.
low on glucose. So a decreased temp might actually be like, oh yeah, and look, they're a little jittery, blah blah blah.
Yeah, and you want to maintain that too. So you have to be on the lookout. If you have a blood sugar baby, a hypoglycemic baby, we want to control their temperature because I don't want them now shivering and losing more heat, which is going to use up more energy,
Yeah.
use up more
Yeah, the
glucose.
basal metabolic
storage.
rate really increases because they are trying to get their blood sugar up. And what they're doing is actually burning off their brown fat, burning off their glucose stores, and not, it's a spiral downward that we want to try to avoid
Yeah.
by all means.
Hypoglycemia. What else?
Hypoglycemia, and we're gonna have that like with our,
Not just SGA and LGA, but also our preemies and our post-term babies too.
so babies that are either born too early or born too late,
Yeah.
if you will, also might have a little sugar
Yeah,
issue.
sugar issue, yeah.
Yeah, that's rough stuff. So post-term babies and hypoglycemia.
Post-term
Oh,
babies, yeah, big
good to
babies,
know.
post-term babies, and your preemies. Your preemies think about too, right? They're little, they're scrawny,
They got nothing.
no fat.
No.
All they got is
reserves
a lot of
whatsoever.
hair and a lot of vernix.
They have no
That's it.
fat, no glucose.
Opposite of your post-term babies, which are no lanugo, no vernix,
Dry,
but
dry.
dry, peely skin. That's all they got to offer, and a lot
Yeah.
of fat. Dry.
I
skin,
told my class
lot
that
of
that
subcutaneous
placenta,
fat.
that placenta signed a 40-week contract and they're in the 2-week.
They're burnt
contract.
out.
They-
They're burnt out.
That placenta stopped working
Yeah.
about 2 weeks
It's
ago.
that extended shift, you know? They've had a
Yeah.
rough shift.
Yeah, there's that it's definitely time to come
Well,
on.
soon, someday soon, yeah.
Yeah. Anyways, so that baby, you know what, there's some other neat things. I basically say a baby later in gestation, like they fatten up and they wrinkle up. So all the wrinkles on a baby, like the soles of the, like the creases on the soles of the
Their will have it,
feet,
yeah.
even their like on their scrotum, everything like wrinkles up.
Yeah.
Everything that's supposed to be wrinkled wrinkles up. And the
The
farther
older
in
you get,
gestation,
okay.
definitely the older you get, and it never stops. Needless to say, you'll find the lack of fat, you'll find the lack of creases or wrinkles or rugae,
On your
in
preemies.
our preterm babies.
Mhm.
Yeah, and it's pretty cute to see they're smooth as smooth. The soles of their feet have absolutely, it's just
Yeah,
smooth.
they're shiny,
Yeah,
thin,
they got
little
nothing.
feet.
Poor little thing. But
They're
they at
cute.
least have the protection on their skin still. Those post-term
Yeah.
babies, everything's all dried and cracked and peeling and
Yep,
time to come out.
yeah.
There's two other scenarios that I just want people to be mindful of. The first one is our jaundice babies.
Hyperbilirubinemia.
Oh,
It's a big
isn't
word.
that a fancy word?
Billy is in it though.
Hyper, meaning
A lot.
a lot. Bilirubin.
Bilirubin, what's that?
Well, it turns out bilirubin is actually, and this is important to know in terms of your patient teaching and such, bilirubin is actually the waste product of red blood cell destruction. So there's a couple scenarios here. Any bruising baby has, like maybe a cephalohematoma, or like they came out fast and they have big old bruise on their face or something like that. Anytime there's bruising, they're going to have more red blood cells that they need to break down and get rid of. The other scenario is when mom's blood is already attacking baby's blood, right? When you got those set up for that. Mom's blood is the antibodies in that have gotten into baby's blood are kind of attacking baby's blood and breaking down red blood
ABO
cells.
compatibility.
ABO incompatibility. So we got a bunch of red blood cell destruction that will level off, but in the meantime, red blood cell destruction leads to increased bilirubin in the baby's blood or in the hyperbilirubinemia. So bunch of blood, bilirubin in baby's blood. What does hyperbilirubinemia cause?
Jaundice.
Jaundice. So that's the outward symptom of hyperbilirubinemia.
Yellow highlighter babies. No, they're not always like that. Yellow.
No, they're not, but
you'll see it a lot too, like in the face. A lot of times starts there.
Yeah.
Forehead, chest too area.
In my hospital, we do a transcutaneous bili
Yep.
check every 12 hours of life.
We do it every 24 unless like looking at mom's blood type.
Yeah.
Oh,
Because our eyes, it's a very subjective I mean, sometimes
It
you
is.
look back and you're like, oh my gosh, how did we miss the fact that this baby looks like pumpkin orange? I look back at pictures of my own child, and I'm like, oh my gosh, she didn't have a bilirubin issue, but all babies have to kind of level out, figure out how to use their own liver to
Yep.
cleanse their blood and stuff. So all babies have this like slight rise in their bilirubin levels that levels off and then just starts coming down as their bodies figure it out. There are times when it doesn't level out. It keeps going up, and so there it's either a problem with the liver, more often related to excessive red blood cell destruction. The other thing that needs to happen is the bilirubin needs to process through the liver and it gets sent to the intestines, where it binds to the protein of either breast milk or formula and gets pooped out. Well, if there's no protein in the intestines, it gets reabsorbed and backs up the system. So not only so we need to make sure there's something in the intestines for that bilirubin to grab onto and
feed that baby.
Feed the
get them
baby.
the poop.
Mhm.
And if that doesn't help and it's still high and it's rising, then we're gonna do phototherapy.
Phototherapy is that blue light therapy.
Blue light tanning bed for the baby.
Yeah, it helps to break down the bilirubin, kind of helps the liver, if you will, break down the bilirubin to get. They still need something to bind to get it out. So phototherapy alone isn't the deal. We
Yeah,
need the frequent
feeds,
feed or sometimes supplement
hydration, yeah.
for our babies. And those tanning beds are all well and good, and they do actually look like they're in tanning beds. We
They
have a
do.
bunch of different technology now that has other ways of doing it. But if they're under the lights like that, they need to protect their eyes.
Yeah.
Yeah.
Eyes in general, that's the two things. So they should be naked, right? Because you want that light to hit their skin.
Yeah, you want
So the only thing
exposure
that
of
should be
skin.
covered, right, is genitals and eyes. Because you want to prevent that retinal damage.
Yeah, we don't want that. So yeah, as much of skin exposed, except for those two areas.
Yeah.
Good to know. Good to know.
Yeah.
What else do we have? We have,
What other complications?
you know
What
what?
about withdrawals?
Yeah, it's fetal, neonatal abstinence syndrome
Yeah.
or withdrawal from like opioids. That's
Opioid,
rough stuff.
alcohol, yeah.
That's rough stuff.
Those are such sad babies.
They are. They're
They'll be
working
so
really, really hard.
miserable. They're so like irritable. They're crying a lot. They're terrible feeders. Absolute poor stock. Terrible feeders.
And the problem is they're burning off so many calories, trembling and crying
And that
they're
cry, that
pooping,
high
pooping,
pitched cry, it sounds like a
high-pitched,
cat.
terrible, terrible. They're
Yeah.
clearly miserable, yet they can't feed well to replace those calories. It's a really rough scenario. And the best thing we can do, is um be respectful of the family. We need to we need to love them.
Love
The
them so
deal is, have you heard of Eat Sleep Console?
Eat, sleep, console, yeah. I
Yeah.
feel like that's the standard now. in
It
most
is now
places.
the
Some
standard,
people
yeah.
do still like, I know the NAS scale, but
Yeah.
Eat, sleep, console.
Eat Sleep Console. So actually, we are encouraging, unless they have another contraindication, we're actually encouraging our moms who maybe are on like methadone or Suboxone or something like that. We're actually encouraging them to breastfeed because it is a small amount of like 1% of their dose is actually getting to the baby. That helps kind of ease them out of this.
Interesting.
Yeah,
I
yeah.
mean, that's good too,
That's the
because that
reason.
might help eliminate that need for like a morphine.
Right. So it kind of weans them off more
Nice.
naturally. It gives the patient something to do to help their baby. I will tell you that our judgment and our attitude to that patient, because we can be very angry at them naturally, like, how could you do this to your baby? But our outward rudeness to a patient is not helpful, right? They already are probably have a lack of coping skills, which may have made them turn to substances to cope with
Yeah.
life stresses. Our judgment and poor treatment of them is not helpful. So just do your best to leave that in your heart and treat them with
Yeah.
kindness. Your kindness might make a difference.
Gotta work on that
As will
implicit
your
bias.
poor
It's
treatment
hard,
of them.
but
Yeah. So
work on
eat, sleep, console. So darkened room, try to bundle them up nice and close and just hold them. And this is
Give
where
them
we
the-
really would like our parents to be involved because they can sit there and hold their babies.
Skin to skin.
Yeah.
right?
All of that stuff. They're working
Warm.
hard though, because we're gonna have babies who stink at feeding, burning off calories. They poop a lot. They just get very disturbed. They have trouble sleeping. So if we can try to get them into that calm, quiet, dark environment for sleeping, maybe they will rest nice bundled up. Their temp is gonna go up because they're working so hard, so we have to monitor vital signs and such. And they're just gonna have trouble. It's a special population that is born with the challenges right from the start. Our kindness and attention can make a difference for the whole family,
Absolutely.
I would say.
Yeah.
Well, talks like this have really
Made you want to go back to being a labor nurse.
they have made me want to go back to being.
Inspired you.
Yeah,
Delivering
I'm not
babies.
gonna. I'm not gonna. But it just reminds me of what an honor it is to be present for this moment in a
Person's
in
life.
a family's life. I've said it before. I don't know how much I've said it this semester, but we are guests in a family's memory. So make it a good one.
Yeah, absolutely.
Yeah. Anything more that you would like to add to this conversation?
No, we've
No?
talked enough.
We've
We've talked too much.
rattled
I
on
know.
plenty. All right. I thank you very much for your attention.
Bye.
Hi, everyone.